Good afternoon and welcome to today's Tuesday topic, a little bit different than what we've talked about before, but I think so incredibly exciting. When ketosis appears, is it always with hyperglycemia? What do you think? Now, pretty much you would know, because if it did always appear with hyperglycemia, there'd be nothing to talk about. So I'm pretty sure you know the answer is, yeah, it doesn't always appear with hyperglycemia. There are other times that we will see patients who are ketotic, who are not hyperglycemic. So first, we're going to talk about patient number one. Patient number one is a 28-year-old man found on the floor by his mom, soaked in urine, reduced consciousness. He has not eaten for 5 days, ding, 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 citing that he wanted to die because he thought people were out to kill him, and he'd taken an overdose 10 days before of 100 Advil tablets. He'd vomited once, but denied cough, denied chest pain, and he has a history of depression and deliberate self-harm. But right now, he's not taking any regular medicine, and he's not doing any drugs or drinking, and his cardiorespiratory, GI, and neurologic systems all appear normal. But what doesn't appear normal is his venous sample. And that's the only thing we're looking at here is his blood gas. There are many other things to look at, but that's all we've got right now. On his venous blood gas, his pH is 7.25. Okay, so we've already identified he's acidotic. Now we're looking at why. CO2 is 37, so it's not respiratory acidosis. Lactate's not significantly elevated. It's only 1.4, but his bicarb is 16. Remember, perfect bicarb's going to be 24, and range is 22 to 26. Remember that when bicarb is down, metabolic acid is up. Metabolic acid is up, pH is down. We think he's got metabolic acidosis, and we would be right. But his glucose is 60. His glucose is low, and he has ketones in his blood. He has an elevated level of ketones in his blood. So he has ketosis, but he doesn't have hyperglycemia. He does not have a respiratory compensation, or he'd be blown off CO2. Lactate level is pretty normal, but he has a very acidotic pH. So he's our first patient. Patient number two, a 43-year-old woman who's taken an overdose 4 days prior to admission. She took 80 cocamidamol tablets. That's really like acetamol. I'm sorry, not acetaminophen, acetamol. They're just anti-inflammatory tablets. And that was after she had an argument with her partner. So paramedics see her. They didn't bring her to the hospital because she's been vomiting, and they felt like she was really at low risk. These not really that dangerous. But since then, she's kind of been feeling lousy with ongoing nausea and vomiting. She hasn't eaten or drinking for 3 days. She's had a history of alcohol excess, but she's abstained for the last 4 days. Past medical history includes alcohol abuse, anxiety, depression, and her regular medication is just propranolol. Examination's normal. And now again, we're going to look at a venous sample in the ED. pH is 7.28, so she has acidosis. Her PaCO2 is 27, so she has a compensation or an attempt to compensate for her acidosis. Lactate level's low, but bicarb is extraordinarily low, meaning that metabolic acid is up. Glucose is 120, and her ketones are 4.3. So she's acidotic. She has metabolic acidosis with elevated ketones and a normal glucose. And our prior patient had metabolic acidosis with low glucose and elevated ketones with metabolic acidosis. Okay, so that kind of brings us to just this basic comparative analysis here, which is ketoacidosis. 3 major reasons. Pretty straightforward. DKA. And the problem with DKA is you don't have enough insulin to actually transport glucose into the cell. And of course, the number one treatment here in DKA is to treat your ketosis by giving insulin and also by supporting your patient by giving them glucose. So that's really important. DKA is an insulin and glucose therapy. Frequently, and more frequently today, we are seeing DKA patients that don't have hyperglycemia. However, they have profound ketosis. Secondly, starvation ketosis, and that trigger is prolonged starvation for greater than 3 days. You can also see starvation ketosis with people who are on keto diets or fasting. Not necessarily talking about that you live in an economy where you don't have food. People make a choice to starve. They're working out. They're only eating ketones. They're on a ketogenic diet, a true ketogenic diet, pretty hard thing to follow. But that, of course, is another reason. And third, and certainly not last, is alcoholic ketosis. And that is starvation is a basic starvation that's following either a binge or a withdrawal from alcohol. And it's a little bit more intricate than the other two. The other two are pretty straightforward. Alcoholic ketoacidosis, not quite so straightforward. And the mechanism for all three excessive ketone productions are very similar. Either you don't have enough insulin or you don't have enough carbohydrates, one or the other. You don't have enough insulin, you don't have enough carbohydrates, and you transition to a compensatory ketogenesis in order to provide fuel to maintain your cells in physiologic stress. So that would be in DKA, starvation, or alcoholic ketoacidosis. You actually transition cerebral metabolism from primarily glucose metabolism to actually ketone metabolism. Now, there's lots of different types of ketones, or at least 3 that we care about and that we look at. So why are ketones developing? Again, no carbohydrate intake, lack of insulin, very severe exercise. You have an increase in your insulin resistance. The most common thing that we see in critical care, increasing insulin resistance, is when we are titrating up on epinephrine and norepinephrine, which promote insulin resistance. From different types of ingestion, salicylate, anti-inflammatory, et cetera, and all of our patients that we looked at so far had some kind of intake that could actually promote ketosis. And then, of course, very stressful types of events. Any stressful event endogenously that increases my catecholamines is going to put me at risk for ketosis. Any exogenous administration of drugs like corticosteroids, like epinephrine, which is a really bad boy, or norepinephrine, those catecholamines that we give to our patients in critical illness, can also significantly increase and impact ketosis. So we're always going to be aware of that. So what do all ketotic states actually share? A role of either insulin and or glucagon. So try to make this very clear as much as I can. Insulin is 100% required to transport your glucose into your cell. It also supports excess glucose being stored as glycogen, and it supports the synthesis of protein and fat. So I'm making this as simple as I can because I'm a simple person. Insulin has 3 primary goals that we think about in this instance. Transport serum glucose into the cell, supports storing excess glucose as glycogen, which is a wonderful glucose reservoir, and supporting the synthesis of protein and fat. Okay, so that is an anabolic event. It builds you up, gives you strength, gives you fat, moves glucose into your cell. The opposer of insulin, which is glucagon, is what plays this critical role here in ketosis. Glucagon is stimulated to be released by the cells recognizing that they are starving. So in a diabetic, their cells are starving. They have glucose in the serum, but not in the cell. The cells are starving. In starvation ketosis, the cells are starving. In alcoholic ketosis, the cells are starving. What will happen then is you will release glucagon. Now, when we release glucagon, you should ordinarily release insulin to balance that. In a person who has an insulin deficiency, they're not going to release the insulin when glucagon gets released. So glucagon is going to cause a significant increase in the serum glucose. So in a DKA patient, glucagon rules, very little insulin. Their glucose is going to go up because their cells are asking for glucose, they're making more glucose available, but whatever glucose they have doesn't get transported into the cell. Now, that's different than starvation ketosis or alcoholic ketosis, because in those conditions, as long as they're not also diabetics, they will release glucagon, make more glucose go up, and make more free glucose available, and that they have enough insulin to transport that glucose into the cellular level. What's really important, though, with a constancy between all three of these, is that glucagon release actually promotes, most importantly, it promotes gluconeogenesis from proteins, but what we evaluate is lipolysis, the breaking down of fats, converting fat to a form of glucose yields ketone bodies. And there's 3 ketone bodies: acetone, acetoacetate, and beta hydroxybutyrate, right? Okay, great. That's a really important, because I want to make sure we appreciate that in diabetics, type 1 diabetics, DKA, glucagon rules in an unopposed state. In starvation and alcoholic ketosis, I don't have any glucose, so I release a lot of glucagon, which means I'm breaking down my fats and converting fatty acids into ketones, but I also have insulin. So because I have insulin, my cornerstone in ketosis for AKA and SKA is that the glucose is normal to low normal, whereas usually, not always, usually in a diabetic, their glucose is going to be elevated. Okay, well, that's pretty straightforward, and it makes it really simple to look at. In all cases here of ketosis, glucagon rules. What you have to do in a diabetic is you have to balance their glucagon with insulin, and in an AKA or an SKA, you've got to be sure they've got glucose. Right? So that makes perfect sense. It's pretty straightforward. It's an easy way for us to look at it. So this is actually from 2006. I'm positive they've updated it somewhere, but it wouldn't change at all. Okay? And that is that you have an absolute insulin deficiency, or you have stress, infection, or insufficient insulin intake. Now, this is looking at diabetics. But what I want you to remind yourself is that in starvation and in AKA alcoholic ketoacidosis, you have a high release of counterregulatory hormones. So the diabetic has an absolute or a significant relative insulin deficiency, absolute or significantly relative insulin deficiency, whereas in AKA and SKA, you're run by counterregulatory hormones. Doesn't matter. In the end, what you're going to do is break down stored glucose if you have it. Now, you have stored glucose if you have AKA or SKA, starvation or alcoholic. You have stored glucose, so you're going to release that. You're going to release that glucose. That glucose is going to be used by the cell. It's going to be used very quickly by the cell. But if you have an absolute insulin deficiency, you have very little stored glycogen. Stored glucose is glycogen. So almost immediately in all situations, you're going to go to proteolysis and decrease protein synthesis. You're going to reduce the use of glucose. You're going to block the uptake of glucose at cell groups that don't really need a high degree of glucose, and you're going to break down fats. Now, we're interested in all of this, but our focus for today is when you're in lipolysis, you send more free fatty acid to the liver, and the liver actually utilizes that free fatty acid and actually produces ketone bodies, ketogenesis, okay? And that ends up with ketoacidosis and some level of lactic acidosis. Now, at the same time, you have a lot of other events that are going on. Probably the most important one is that typically your patient is going to have some glucose wasting, especially early on, glucose wasting at the kidney. Following that will be water. Your patient will have an osmotic diuresis. And what's going to end up happening is they're going to be hypovolemic. So let me say, SKA, starvation ketoacidosis, AKA, alcoholic ketoacidosis, and DKA, all require fluid resuscitation because they've lost a fair amount of fluid. they've urinated themselves almost into hypovolemic shock, and they may actually be in hypovolemic shock when you see them. Now, I just want to talk for one moment about ketones, okay? So there are 3 ketone bodies: acetone, very minimal contribution to anything that's abnormal. It's the least abundant, and it doesn't promote the release of metabolic acid. It's not acidotic. Acetoacetate is the second most common ketone body, and it has an acid effect of 3.58. So that means that its ionic effect is very profound. If I'm putting acetoacetate into blood with a pH of 7.4, depending on the amount I'm placing, I'm going to drop my pH very rapidly. But typically, it's not the one that we focus on the most. We focus on the one that's the easiest for us to evaluate, and that's beta-hydroxybutyrate. It's the most common ketone body, and it is quite acidic. Not as acidic as acetoacetate, has a pH of 4.70. So it's going to drop my patient's pH when it's being released into the blood. So again, we take a quick look at this. This is such a fantastic and incredibly busy visual, but I just really want to relate this to the whole perspective of autonomic response to stress, releasing adrenaline, epinephrine, and noradrenaline, norepinephrine, okay? What adrenaline does, and that's so important for you to remember, suppresses insulin, decreases circulating insulin levels, also promotes insulin resistance. So all by itself, it's going to make your patient hyperglycemic, and by the way, my friends, ketotic. So when you get a patient back, let's say from the OR, they come back from open heart surgery and they're on epinephrine, the preferred juice of the CT surgeon, you can almost 2-to-1, if your patient's on epinephrine, assume that they will be A, mild to moderately hyperglycemic, and B, mildly to moderately acidotic, partially because of ketosis. Okay, so by the way, for your patient to do well after CT surgery, if they're on epinephrine, they've got to go on insulin. They've got to go on insulin. They need to be on insulin whether their glucose is elevated or not if they have ketosis. If you have ketosis, it can be very helpful to go on insulin. So it's very important for us to remember that, particularly if, of course, if you're a diabetic and you're euglycemic and ketotic, you've got to go on insulin. If you're on epinephrine and you have suppression of insulin secretion, so remember what I'm saying to you, epinephrine-induced ketosis is suppression of insulin, which means you need insulin. With AKA, alcoholic ketoacidosis, SKA, starvation ketoacidosis, your problem isn't insulin, so you don't need insulin. You need insulin whenever insulin is your problem, okay? So that's really, really important for us to appreciate when we're taking a look at this whole conglomerate and the conversion factor and the basic acetyl-CoA cycle and the Krebs cycle and how we're actually utilizing our carbohydrate chain. Okay, so I don't want to say anything. Well, people are like already like, oh my God, what are you talking about? Here's what I'm talking about. In order for you to utilize your carbohydrates, you have to have thiamine. And we all know that in SKA and AKA, you have a thiamine deficit. It's vitamin B1. So in order for you to actually metabolize the glucose that you're receiving, you have to have thiamine. You cannot give glucose support to an SKA or an AKA patient without actually assuring that they have thiamine. They will not be able to metabolize it appropriately, and they will only continuously produce lactic acid and acetoacetate because they won't be able to metabolize appropriately, which is why thiamine is always part of the profile of feeding somebody with SKA, starvation ketoacidosis, or treating somebody with AKA, alcoholic ketoacidosis. This is not your problem here when we talk about the diabetic patient or the induced diabetic, which is that suppression of insulin secretion. Their problem is purely insulin, which is why I love this visual. I hope that it's helpful to you in terms of understanding. Okay, so in ketoacidosis, right, you have ketone bodies with the exception of acetone, which doesn't really donate acid into the blood, but acetoacetate and beta-hydroxybutyrate all donate metabolic acid into the blood. So those ketone bodies are going to be linked to acidosis. Frequently, those patients are hypoperfused and dehydrated, or they have some secondary effects of alcohol affecting their osmolarity and their hydration status. So they frequently will also have lactic acidosis. Not uncommon to see ketosis plus lactic acidosis. More on that in a little bit. Okay, so they got lots and lots of free fatty acid, and that's going to actually cause them to be mildly to moderately acidotic. Just in case you don't remember, normal blood ketone levels less than 0.6 millimoles, 0.6 to 1.5 is mild elevation, 1.5 to 3 is moderate, and greater than 3 is significant. When you have ketone levels at greater than 3, you now are going to say, uh-oh, it's either DKA or AKA. That's not typically what you're going to see in somebody who has starvation ketoacidosis. So a defining moment here, starvation ketosis. In extremes of starvation, typically that is 2 to 3 days of fasting. Your stores of free glucose have been utilized. Your glycogen, which is the reservoir of glucose, has been broken down. You're going to move to fatty acids for primary fuel. That's lipolysis. And at the same time, you're going to break down proteins. Your muscles are going to break down, and you're going to release both amino acids, lactate, and ketone bodies into the blood. Now, lactate and amino acids can be converted into glucose by the liver, answering the call at the cellular level for glucose, but you've also released glucagon, which inhibits the uptake at non-primary glucose-dependent organs, limits their uptake of glucose. But this is basically what happens when you see somebody who is fasting or starving, that you start to see muscle wasting and cachexia because of this whole program. Okay, so when we see a patient, so they come into the emergency room, we're talking with them, they haven't eaten, they, maybe not at my hospital, but maybe at yours. Oh, I've got a high school reunion, I've gained 28 pounds, so I went on a starvation diet and I'm on day 6. Okay, haven't really been eating, online, I read about this drink and I'm drinking the drink and I'm eating those gummies from Oprah and I'm going to lose weight. This 5-day, 6-day fast. And that they come into the hospital because they feel lousy. Now, the very first and most important thing is their blood glucose is usually low. They've been using up their available glucose. They've broken down their stored glucose. They're using that up. You got to be sure that they're not diabetic. And basically, you're just asking about their history. Are you a diabetic or are you an alcoholic? We're asking. And no judgment. I just need to know the truth so I can make a good diagnosis. Typically, the acidosis is really, really mild. So that means their pH is usually above 7.25 or so. Sometimes it's at 7.32, 7.34. It's typically a little less than 7.35, but the bicarb usually doesn't drop that much. Typically, it drops down to about 20 or 19. And when we see their blood, we look at their blood, they don't have that many ketones. Remember, they've broken down their stored glycogen. They've gone a little bit to proteolysis, and they've gone a little bit to lipolysis, but having done that, they have just enough fuel for them to stay alive. So they're mildly acidotic, unquestioning. They're not diabetic, they're not alcoholic, their blood glucose is low. And of course, what they need is glucose. So if their blood glucose is low and you give them an amp of D50, fantastic. That's going to help them, although rapid correction may be problematic in the end. Okay. Now, our number one goal will be to start carbohydrate intake. So the first thing we're going to do is we're going to start an IV. We're probably going to put them on D5 half or D5 LR. Sometimes they may need full D5W. Sometimes they may need D10 or D50, D10 as a drip, D50 as an administration. But the thing is, you don't ever want to replace their glucose without also looking at their electrolytes. And the main ones are for these patients, same as with AKA, with alcoholic ketoacidosis, potassium, phosphorus, magnesium. So you're not given D5 without also making sure that they're getting electrolyte replacement. So that's got to be a good discussion of nurses at the bedside, particularly, of course, these patients you're going to see in the emergency department. You need to have some discussion about this. This also is going to be probably pretty similar. I don't know about you, but in my situation, oftentimes we see patients 3, 4, 5 days who haven't gotten fed, who don't have an OG tube, who don't get parenteral feeding, maybe aren't getting any D5W or probably just getting LR or plasma light. They also are now in SKA. And that complicates everything because now they may have mild acidosis on top of severe acidosis from hypoperfusion. Now, the big concern here is that as you start to replete their glucose, so you're doing that with IV D5W or D5 or D10 or D50, what you can see is something called a refeeding syndrome. Now, refeeding syndrome doesn't necessarily require that you are eating. It means redelivery of glucose into the cellular level. So first and foremost, just want to be sure that we're really being cautious with these patients. We're really meticulous about eyes and nose, about change in weight. We're watching them like a hawk for neurologic signs and symptoms, trying to keep them very hemodynamically stable. And really, really important for us to just apply that strategy when we start refeeding. This is a beautiful visual that comes from a much older journal. It's from the Psychiatric Bulletin because it was in relationship to anorexia, and it was published in 2007. But it's such a great visual that I really wanted to use it here. So this is starvation, malnutrition, decreased glucose. So every patient that's in your unit who isn't getting at least 30 kilocalories an hour of D5, of glucose, is probably going to have a starvation malnutrition complex at around day 3 to day 5. So you might say, oh, well, half of my IV drips are mixed in D5W. That's really great. But if you're only giving them once every 6 hours, probably not enough to replete them. And it is putting them into starvation. And I think most of us are aware that in today's world, we don't want to starve patients. We always try to start something, even if it's a trickle feed through the OG tube, or you're trying to give them some carbohydrate solutions. It's really, really important in terms of stability and stabilizing the patient and preventing this starvation. Okay, so if your actual glucose intake goes down, your insulin output will go down because insulin is only released in order for you to match your glucose. Your glucagon release will go up, and your glucagon release, remember, is going to block insulin uptake at the cellular level, and it's going to promote the making of glucose from non-glucose products. Those non-glucose products, gluconeogenesis, are protein and lipids. Okay, so really important to appreciate that in that starvation patient, I'm looking at urine urea nitrogen that's going up because you're catabolizing your proteins. Your BUN may be normal, but it may also go down. And your ketone bodies are present in the blood, but they are most particularly acetones, so not significantly conferring an acidotic effect. On refeeding, what that means is, in whatever way, we have determined we're going to increase your glucose. Maybe now you're eating, maybe I'm giving it to you IV, I'm giving it to you parenterally. Now we've increased your glucose. Now your insulin will go up to match that glucose and your glucagon will go down. What's going to happen is your cells are going to take up more glucose. And as they take up glucose, what's also going to occur is an uptake in phosphate, magnesium, and potassium. So prior to this time, your potassium level may have been 4.5 in the serum, but once I give you glucose, your potassium level may drop down to 2, or it might drop down to 1.5. The other really important thing in refeeding, so remember here in SKA, the problem is you didn't have glucose. In the end, that's the only fuel that's important at the cell is glucose. That's why carbon chains are so important. But in refeeding, what also is really important is to remember that thiamine is used in the Krebs cycle and other pathways, the pentone pathway, other pathways we don't really care about. Just want to remind you that you're going to aggressively use thiamine when we restart fueling you with glucose. You're going to consume your thiamine. And so what's going to end up happening is you're going to have a thiamine deficiency and an AP deficiency, ATP, which is your energy store. Your thiamine's going to go down, your energy store is going to go down, and now all of that glucose that we're giving to you is actually going to generate more metabolic failure. That's a really important thing for us to remember when we're talking about those patients. Now, something that is critical, and this is going to be for both SKA and AKA, not DKA, is this big alteration that occurs can actually present with a failure of cerebral glucose metabolism. And that's going to present as Wernicke's encephalopathy. We're going to talk a little bit more about that a little later. There's a beautiful visual that this visual did not come from the psychiatric bulletin, but from the Journal of Intensive Care Medicine, the British Journal of Intensive Care Medicine. But it's such a great little visual that just reminds us of all the things that we can see in patients when we do refeeding. It can actually end their life. But one of the most important complements for me to remind you about is that with SKA and AKA, you're going to give glucose, but at the same time, you're going to actually support potassium, phosphate, magnesium, and thiamine. Now, we're not going to talk about thiamine with DKA. That's not a worry for us with DKA because DKA is a problem with insulin. This is a problem with glucose. So really, really important. Now, once I give you glucose, you're going to start to limit your glucagon release. You're going to upload your insulin release, and that's going to promote shifting the glucose into the cell. When glucose shifts into the cell, potassium, phosphate, magnesium will also shift into the cell. And guess what else will shift into the cell? Fluid. So we can see that now as we shift, we're going to see a fluid shift. And that fluid shift can then present with pulmonary edema and with heart failure and other kinds of conditions that you see here that are all really important in terms of looking at those patients and trying to protect them. So one of the things I thought was really, really helpful for us is to say, when we see patients, we should always have this kind of concept. Okay, somebody who's quite thin, BMI less than 16, they've had an unintentional, they say, weight loss of greater than 15% in the last 3 to 6 months and have had little to no nutrition for the last 10 days. And when you're looking at them, they have low potassium, phosphorus, and magnesium. You're not going to give them glucose until you've given them some electrolyte resuscitation. Okay. If they have two of the following, so their BMI is a little bit higher, it's still low, 18.5, it's a low BMI, and they've had some weight loss that's only been about 10% over the last 3 to 6 months, and they haven't really eaten anything over the last 5 days, and they have a history of alcohol or drug abuse. So this is really SKA over here, this is AKA over here. Both of these conditions are at risk for refeeding syndrome, okay? So really important when we look at potassium, phosphorus, and magnesium on our patients, what you want to remind yourselves that you want them to get to a normal reference range, and you may need to resuscitate this, okay, to get them to a normal range before you give them glucose. So that's always really something important. Our physicians might write an order. They may not say resuscitate potassium, phosphorus, and magnesium before you give glucose. They say hang the glucose, or we think we're going to make things easier. We're only going to go to Pyxis once. I'm going to get that D5W. I'm going to hang that D5W. Then I'm going to administer potassium, phosphorus, and magnesium over time. But what I actually can do in this situation is actually be the cause of acute and profound refeeding syndrome, which is life-threatening. So I have to think about that with AKA, and I have to think about it with SKA. Okay, so now we move to AKA, alcoholic ketosis, just some little definition. Don't let it be overwhelming, okay? So chronic alcohol abuse and liver disease either abrupt withdrawal or a binge, one or the other. I stopped drinking 4 days ago. I've been on a binge for 4 days. And when we draw that patient's serum level, their methanol levels may not be very elevated because it may already be metabolized. So that's really important. I'm not going to actually rely on your serum level of alcohol or methanol to tell me what's actually occurring for that patient, right? Because it may already have been metabolized. Now, what's really important to remember is that this alcohol actually is a sugar, and it actually goes through a process. And at the end of that process, it creates what we call NADH, and that's a hydrogen ion there. But NADH suppresses gluconeogenesis and reduces glucose, meaning that my patient, in order to have fuel, is going to have to release glucagon and promote ketosis, okay? The other thing is that if you've had a withdrawal, of course, as we know, you're very agitated, your heart rate is up, you have very high circulating catecholamine levels. Those catecholamines also will cause lipolysis and ketosis. Very important here, because in order to stabilize your NADH and your NAD, which is what I want to stabilize, not your NADH, your NAD, I have to have thiamine. Have to have thiamine. So for SKA and AKA, the very first thing you're going to think about is thiamine. Before you give glucose, you can give thiamine at the same time that you're giving electrolytes, but before you give glucose, you need to think about thiamine. Okay, so really important to appreciate with alcoholic ketoacidosis, right? That interference that's related to NAD and conversion to NADH actually diminishes gluconeogenesis and promotes insulin resistance. So I'm going to increase my glucagon. Glucagon inhibits insulin, and it inhibits insulin uptake. Okay, now the problem is that I'm not going to have successful high level of stores, right? I'm not going to have a really high stored glycogen. So my glucose may go up a little, but it's not going to be significant. Okay, so I actually am going to suspect this very significantly because you have told me that you're an alcoholic. You have told me that you've been 5 days without a drink. You have told me that you've been on a binge for 3 days. The honesty and trust that we have together when you tell me about your alcoholism and where you've been with that in the last few days is going to actually guide me to a good pathway. Because, by the way, you're going to have a wide anion gap and you're going to have high ketones, which makes me think that it's DKA. And I still have to rule out, even if you don't have hyperglycemia, I still have to rule out, is this euglycemic DKA? Or is this alcoholic ketoacidosis? And remember, I can't rely on the measurement of alcohol in your serum because that may have already been metabolized. So I've got to have a really good, honest conversation. I have to really investigate the history, have to have some trust with my patient. So again, usually a chronic alcoholic generally has some history with your ED, often will present to the ED, not stops drinking, they stop drinking, and they haven't really been drinking much, so they're not really eating, they're not really drinking. Typically, they have very non-specific symptoms that don't really give me any kind of information except for one thing. They tend to be normal to agitated, whereas DKA patients will be typically lethargic to obtunded. And they may also be showing some other clinical signs of withdrawal that, of course, you all are very well versed in, you're always looking for. Remember, they will have acidosis because they have ketosis, and they have ketosis because of beta-hydroxybutyrate and acetoacetate. Not really acetone like in SKA, it's the higher level acidotic contributors of ketone bodies that we're going to see here. And the most common one will be the beta-hydroxybutyrate, which is what we all measure when we do a lab. Okay, but it means you have to suspect this. You have to be concerned that this is not just alcohol withdrawal, but that it is alcoholic ketoacidosis. Patient may have very profound alterations in their electrolytes, because they've been vomiting, they haven't been having much intake, but also really important is that their lactic acid levels may be very high. Now, the reason for that is that your liver is responsible for the conjugation clearance of lactate. So if you're an alcoholic, you may have a very high lactate level, and we automatically say, oh, elevated lactate, you've got sepsis, you've got lactic acidosis. It's not necessarily true. They just may have an elevated lactate level because they have failure of conversion, because they have liver dysfunction secondary to their alcoholic condition. Again, that's, I'm making a connection here. This is not a judgment. This is a connection that the liver is responsible for the clearance of lactate. If I'm a chronic alcoholic, I may have some failure of liver conjugation. And if I have failure of liver conjugation, I'm going to expect to see an elevated lactate. I'm not necessarily ringing the sepsis bell because your lactate is up. 400 causes of elevated lactate. It's a lousy thing to use to look at sepsis. It doesn't really tell us that. It just tells us either you have hypoperfusion of lactic acid or you have failure to clear lactate. And that's a pretty common problem in my population of patients. Okay, so when we initially look at those patients, we're trying to rule out diabetic ketoacidosis. Typically, we're going to rule that out based on your history, and we can look at a hemoglobin A1C. That's going to give us good information. Do you have pancreatitis? Do you have methanol or ethylene glycol poisoning? Most of the time, I'm just saying, do they have DKA? And then I'm going to consider whether or not they have pancreatitis. I get all that information on the chemistry. It's pretty good. I'm pretty clear at this point. But your patient will have a high anion gap, a wide anion gap. Sometimes that's referred to as HAGA, high anion gap acidosis without the P. So if you ever see that when you're reading about AKA or SKA, that's what that means. But SKA, of course, does not have a wide anion gap. Alcoholic ketoacidosis and DKA do have a wide anion gap. So again, it's really based on your history. You have a wide gap, you have metabolic acidosis, you have ketonemia. That sounds like DKA. And by the way, glucose doesn't always make the difference between whether you've got DKA or not, because you could have euglycemic ketosis, diabetic ketoacidosis. Magnesium and phosphate plus potassium, those are going to be abnormal with DKA as well. I really had a bad spelling day here. I'm so sorry because I was writing these slides earlier today, but maybe I was having a euglycemic acidosis. I don't know. I would try to make that funny, but it didn't work. Okay. So the other thing that's always really important about alcoholic ketoacidosis is a lot of times when patients are vomiting or they have diarrhea, they'll actually have metabolic acidosis that's being masked by metabolic alkalosis. And that can be quite important when we take a look at diagnosis. Okay, so for AKA, very similar to SKA, we're going to give you thiamine. The difference for AKA from SK is we're going to use benzodiazepines. For CWAS or GAWAS or whatever alcohol withdrawal syndrome program you're working with. We're going to use benzodiazepines. Those are going to be pretty significant. There may be other agents in your protocol, and that's all really wonderful and good. We're going to reintroduce glucose, but we're going to be aware that you can have refeeding syndrome. So remember, we typically are not going to want to give you glucose without repleting your thiamine. Okay, now if you've got really severe acidosis, I actually am probably going to order you to receive continuous IV insulin plus dextrose as an infusion. Again, after I've given you thiamine, after I've given you fluid, after I've given you electrolytes. That's going to be what happens in the first hour. And now I'm going to start to reintroduce glucose, but I'm not going to do that without thiamine on board. Other things that I'm doing about treating your AKA, your alcohol withdrawal, those are going to be the standards of practice that you do in all your institutions, how you're evaluating, what agents you're using to support decreased agitation, however much you use, that's all part of your protocol. What I want you to be aware of is IV fluid, electrolytes, thiamine, and then reintroduction of glucose. And that's by IV dextrose, remember D5, D5LR, D10, D50, oral carbohydrates. You're not getting it until I get thiamine on board. And that's going to be so incredibly and profoundly important. Now, that's really even more important than in SK. It's important in starvation ketosis. It really is helpful, starvation ketosis. I'm probably not going to break my bank if I'm given thiamine and glucose at the same time in an SKA patient. I am going to break my bank about the AKA patient, okay? Because especially if you're chronically alcoholic, you are at risk for Wernicke-Korsakoff syndrome, which is a profound cerebral degeneration methodology. And we're going to take a little quick look at that in just a moment. So with AKA, I am going to want to give you thiamine before I give you glucose, and I'm going to continue thiamine for several days. Probably, most likely, you're going to continue it for 3 to 5 days, okay? Thiamine is part of the cycle that allows us to convert from carbon chain to usable fuel, okay? Thiamine is required in order to create usable fuel. So that's really important. If I give you glucose without thiamine, you're going to get worsening lactic acidosis and ketosis. And that acidosis obviously is acid. So it destroys your cellular structures, but it also can promote cellular suicide. Cellular suicide, the term we use is not cellular suicide. We use the term apoptosis, which means cell death. The cell murders itself. So I want you to remember, thiamine protects my cells from cellular suicide. It's a way to protect my cells from cellular suicide. Okay, so what is Wernicke-Korsakoff syndrome? It's typically something that you see in patients who are starving and in patients who are alcoholic. And that's because they have a lack of vitamin B1, which is thiamine, okay? These are not really different conditions. They are the same at different stages. So that's why typically you see it as Wernicke-Korsakoff instead of encephalopathy and amnesic syndrome. This is a continuum of the same disorder, okay? So again, thiamine, vitamins, magnesium, potassium, phosphorus. I'm going to try to protect you from Wernicke encephalopathy, and everyone appreciates the encephalopathic brain or psychosis and amnesia. We're really going to try to help you with that. If you know anybody who's an alcoholic, make sure they're taking vitamin B1, right? Try to get them to stop drinking. That sounds good and it sounds right, but it's a hard thing for us to do. And just remember that vitamin B1 is involved in that glucose metabolism, and in particular in the way your cerebral cells use glucose. After I've done that, that's step one. Then I'm going to give you D5 solution, and I'm going to continue with replacement of electrolytes and potassium. And typically, the ketoacidosis and GI symptoms associated with this, some of your cerebral symptoms may disappear, but typically this is a permanent development of encephalopathic brain. So I'm gonna try to reduce your symptoms. Usually they're going to reduce really, really, really quickly. And just as a reminder about that thiamine deficiency, is it really significantly reduces the energy that can be used by your brain, and it promotes neuronal damage. So really, really important. Okay, so some of the things you see with patients, right, is you see things that really almost look strokish, right? They have conjugate gaze palsies, sluggish pupils, ptosis. They have a confusional state. They're very inattentive. They're very disinterested, or they may be agitated. Normally, you don't see a coma except sort of at the very end stage. They may have an unbalanced walking, a gait ataxia, and they may have some neuropathies that are associated with that. Okay, so take home here, AKA, common in patients with alcohol use disorder. They have a wide gap acidosis. They've told you that they've withdrawn from alcohol or they've been binge drinking, which helps you to narrow in on the probability that this is AKA, because otherwise it's going to look like DKA, wide gap, metabolic acidosis, glucose may be normal, might be slightly elevated, might be a little bit low, but they've got ketones in the blood. So really important to recognize that if we can intervene quickly in the recognition of this ketosis, if we can intervene quickly, we can resolve this almost completely. And if we don't intervene, it may result in sudden death. So last but not least, I'm not going to spend too much time on this because everybody here is treating DKA. So just remember, DKA is predominant in type 1 diabetics, but it can occur in type 2 diabetics or also in latent autoimmune diabetes. You can see DKA. DKA comes from a shortage of insulin. So remember, because I don't have enough insulin, my cells are saying, feed me, Seymour, I'm starving. Glucagon is released, and glucagon supports the breaking down of proteins and the breaking down of fats, promoting the yield of ketones. So I want to remind you, right, acetoacetic acid and beta-hydroxybutyric acid are both profoundly acidotic, not like acetone. Acetone is not really acidotic. So these two acids are significantly released in these patients, conferring a very profound metabolic acidosis. So first and foremost, if they have high glucose, they're going to pass that glucose at the kidney. Water will follow. Where water goes, so go electrolytes. So if my patient's been hyperglycemic at home and he says to me, I've had polyuria, I know you've lost water and electrolytes. You also are going to lose your ketones. Ketones, along with water, are going to pull sodium and potassium. So I'm going to waste sodium and potassium in the urine. So typically, they're going to be hyponatremic. Okay. Now, they could be hypernatremic if they don't have any free water uptake. So hyponatremia or hypernatremia, I want to just make sure we appreciate, doesn't really matter. And by the way, whenever you want to know how dehydrated your patient is, you're going to say 2 times sodium corrected. 2 times sodium plus glucose divided by 18 equals osmolarity. 2 times sodium plus glucose divided by 18. Nobody wants you to memorize that. Don't worry about it. What I want you to remind yourself is that for every 100 milligrams of glucose above 100, you have to go back in order to know how dehydrated your patient is. You have to add 3 to your measured sodium. So if my measured sodium was 130, I might have to write that down because I might forget. And my measured glucose was 1,000. That's 900 above 100. That's 9 times 3. 9 times 3 is 27, I think. Yeah, 27. Good. 27 gets added back to that serum sodium of 130. My patient's corrected sodium, not what their real sodium is, but what their real dehydration is. Their corrected sodium is 157. They are profoundly dehydrated. Profoundly dehydrated. Now, they may appear hypernatremic because they've lost lots and lots of water. They've lost water first and electrolytes second. So they may be hypernatremic, but more likely with DKA, you're going to see basically a false hyponatremia. They also are going to be, despite what you see, they are going to be profoundly hypokalemic. And why that's so important for us to appreciate is that they're wasting water and electrolytes along with that glucose, so they're wasting potassium, but also your cells uptake the metabolic acid, the hydrogen ion, that's the metabolic acid, and your cells release the cellular potassium. So what you actually see is this movement of potassium into the serum, that's the extracellular migration. So serum potassium is overpredicting cellular potassium. And as soon as you treat that patient with insulin, potassium is going to go into the cell, and the patient's going to go from having a measured serum potassium of 5 to a measured serum potassium of 1.2. By the way, your responsibility, my friends, when you're treating a DKA patient, you need to monitor their serum K, and you need to ask early on for potassium replacement. In these patients, you never want potassium to be below 4. So for me, I'm not putting you on insulin if your potassium is 3.5 in DKA. I want potassium first, insulin second. So these are things that we think about when we're at the bedside. Now, I love just this little visual that just reminds us that we don't have insulin. So we're releasing adrenaline, or we're receiving exogenous epinephrine that promotes lipolysis. Glucagon is released, that promotes lipolysis and glycogenolysis. Glucagon is released, that promotes glycogenolysis and gluconeogenesis. Cortisol is released, that promotes gluconeogenesis. So these are all going to make glucose go up, Glucagon and cortisol make glucose go up. And lipolysis is going to make ketone bodies go up. Lipolysis is what makes you acidotic in DKA. Okay, so in general, in the old-fashioned view, and probably anytime you take a test, you're going to be asked, this is going to be what they're going to say to you. In the old-fashioned world, when things were not well controlled, pH less than 7.3, bicarb less than 18, positive ketones, hyperglycemia, usually blood glucose greater than 200. But over here, I've said the least important thing is your hyperglycemia. If you've got ketones in your blood, I've got to rule you out for one of the three, SKA, AKA, DKA. And I'm going to assume you have DKA if you have a history of diabetes, and if you have an elevated hemoglobin A1C, I'm going to treat you like you have DKA. So we certainly know that we see DKA a lot, but I want to now talk about euglycemic DKA. Euglycemic DKA is commonly seen in patients under the age of 12, in patients who are on high-dose glucocorticoids, atypical antipsychotics, some immunosuppressant agents, not that many. And for me, a very important part is poor access to medical care coming from uninsured and lower socioeconomic status, but also the increasingly aggressive use of SGLT2 inhibitors that promotes euglycemic DKA. Okay, now we know DKA occurs most commonly because you've omitted insulin. It also occurs when there's an extraordinary demand for glucose at the cellular level. I'm fighting an infection, I'm fighting sepsis, I've had an MI, I have a high thyroid output. All those things increase glucose demand at the cellular level. And everybody appreciates what the treatment is. Fluids, IV therapy, insulin, and dextrose to support the insulin, because if I just give you insulin, I'm going to put you into further ketosis. I cannot just give a DKA patient insulin. I've got to give them dextrose to go along with the insulin until the cells have been happily fed and glucagon release has stopped, so ketosis stops. And of course, electrolyte replacement. When you use SGLT2s, I'm going to give you the list of everything that's to date has been approved. There's a lot of agents coming around the border or around the corner. SGLT2 inhibitors are the newest class. All these agents that talk about weight loss, all of them are SGLT2 inhibitors. It is not uncommon to see euglycemic ketosis with these patients. You, as the bedside nurse, need to be aware of that. You're looking at the patient, you know they've got a diabetic history, you're actually talking to them what agents they're on, and you get your first chemistry profile back and your bicarb is low. Your bicarb on your chem profile is low. That means your metabolic acid is up. It's time to start thinking the patient may have euglycemic ketosis. Here are the primary agents right now. Ozempic is also one of these agents, right? So you see all the Jardiance and Farxiga, and I haven't really seen many ads for Invokana, but I see a lot of stuff for Farxiga, Jardiance, and Ozempic. So these are new agents. They are life-saving. They are fantastic, but they do put your patient at risk for euglycemic ketosis. So this basically what's really, really important about this SGLT2 inhibitors is that they are actually promoting more lipolysis. They promote more lipolysis. And they promote insulinopenia, meaning a reduction in insulin release. So oftentimes we're going to see those patients with a euglycemic ketosis. Okay, so now we're going to look at a woman in her 40s, type 2 diabetes mellitus, presents for scheduled cerebral revascularization from moya, which is a form of neurologic reduction of blood flow. Okay, she's on multiple medications at home, right? Metformin. She's on two agents that are newer agents, one of them being SGLT2 inhibitors. She's on thyroid, she's on atorvastatin and metformin. She's on a gram in the morning and a gram at night. And anti-hyperglycemics were held on admission. Okay, now, by the way, holding SGLT2 inhibitors, SGLT2 inhibitors on a hospital admission is always a good thing. It's always a good thing because it can really precipitate euglycemic ketosis. And her blood glucose levels were managed using insulin lispro. Immediately after surgery, she looked pretty good. She got extubated. She went to the ICU so that they could monitor her cerebral vascular recovery and assure that she didn't have any deficits. But a few hours after she was transferred to the ICU, she developed slurred speech. They took a good look at her head. She had an acute left cerebral infarct. They gave her isotonic crystalloids, phenylephrine, fludrocortisone, which is a mineral corticoid to help sustain her perfusion pressure goals. And over the next 24 hours, she got more and more and more and more and more acidotic. pH was 7.01. PaCO2 was 11, so she was compensating. Anion gap went up to 27. Lactate was normal. Bicarb drip was started. And during first 48 hours postoperatively, nutritional support had not been started. So she had profound ketosis, ongoing ketosis, not receiving glucose, and she basically had SGLT2 induced euglycemic ketosis. So let's just take a quick look at her. Here she is, her first to her fourth measure, right? So her potassium went down. They gave her potassium. She went back up. Chloride went up. That's very common. Her total serum CO2, which is her bicarb, went down, 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 down. Her BUN stayed pretty stable. Creatinine stayed pretty stable. Glucose was always relatively normal. Glucose was always relatively normal, but look at her gap. So she has a wide gap. She has a low bicarb. She has a little bit of an elevation in serum chloride, not very much, and I'm not really that worried about her. But on her sample, her pH was 7.30. So not profoundly acidotic, but you can see over here, anything that's greater than 0.3, look how high her butyric acid is. She has a moderate to severe ketoacidosis with a normal blood glucose. Okay, so by the way, really important to remember, you've got a normal blood glucose. I put you on insulin to stop your ketosis. I put you on insulin without glucose. You're going to bottom out your blood sugar. That's going to make you go into more ketosis. And we're seeing that every single day. This is just a beautiful visual that just reminds us about patients that are at risk for DKA and looking at patients, most particularly type 2 diabetics or LADA, which is that latent autoimmune diabetes of adults, usually in quite young folks. These are the folks, type 2s and LADA, because of their, first of all, this patient isn't even known, but this patient, because of what we're actually using to treat the patient, again, using metformin plus SGLT2 inhibitors, they are at risk for euglycemic DKA. So when we look at our patient, we talk about their diabetes, we talk about their diet, and then we say, are you at high or low risk for euglycemic acidosis? And that's a really important thing. Now, this is really more for diabetic educators, which I'm not going to actually talk about for you right now. I'm just going to remind you, when you see acidosis in somebody who's starving, in somebody who is alcoholic, in somebody who has a history of diabetes, when you see acidosis, the first thing you should think is ketosis. Even though the euglycemic DKA, and that's typically going to be the person on SGLT2 inhibitors, the euglycemic DKA patient, the AKA patient, the starvation patient, all have normal to low glucose. They may have ketosis. For AKA and SKA, you're going to give glucose after restoring their thiamine and their electrolytes. For the DKA patient, you've got to give them insulin, and you must give them glucose to support the insulin that you're giving. Sometimes nurses will say to me, why am I giving a patient D5-LR at 150 an hour when they're a diabetic? Because they have a wide gap and a normal glucose. Why am I giving a type 1 diabetic DKA patient glucose when I work so hard to get their glucose down below 150? Because they still have a wide anion gap, and because your insulin is for treating ketosis. You're using insulin for ketosis in the absence of insulin, which means you must add glucose. In DKA, you're using insulin for the treatment of ketosis in the absence of insulin, and you're going to give glucose to balance the insulin. In the AKA patient and the starvation patient, you are going to give glucose because they need glucose. They don't have a problem with their insulin. They need glucose. But prior to that, you're going to give them thiamine so that they can metabolize appropriately the glucose that you gave them. So again, with euglycemic DKA, patient's acidotic, has a low bicarb, has high ketones, and typically has a wide anion gap. And when you compare them all together, this is just reminding you, with starvation ketosis and AKA, right, you don't really see much acidosis in starvation ketosis. You do see some acidosis here in AKA, but the problem really isn't insulin. The problem is they don't have glucose. Over here, when we look at any of our DKA or HHS configurations, these patients' problem is that they don't have insulin. Whether their glucose is elevated or not, you can see here, euglycemic DKA, same glucose level as AKA and starvation. This is going to be low, but what they actually have is a history of diabetes, and they're on SGLT2 inhibitors. So you're going to give them insulin, you're going to give them glucose. DKA, you're going to give them insulin, and you're going to give them glucose if they still have a wide anion gap and their glucose is now normal. Same thing with DKA-HHS and the same thing with HHS. Everyone's going to get fluids. Everyone's going to get insulin. And by the way, if you're on continuous IV insulin, everyone who's on insulin is going to get glucose. So remember, everybody needs fluid. Everybody needs electrolytes. AKA and SKA need thiamine, and they respond to glucose. There may be a rare occasion that they need some insulin. That's only if they're really profoundly acidotic. DKA must have insulin plus fluid and electrolytes, and they may need significant glucose to balance the insulin that you're giving, because the goal of insulin in DKA is not to get the glucose under control. The goal of insulin in DKA is to stop ketosis. I want to thank you so much for joining here today. I hope this was meaningful for you. I appreciate very much that you took time in your day to spend time with me. And I hope that we see each other again, hopefully tomorrow or next week. And thank you very, very much.